would like to introduce Mr. Kwame Turner, who is the founder of bEHR Health Systems, and he will provide information on how he utilizes data to monitor wellness.
Good morning. Good morning. So, as you mentioned, my name is Kwame Turner, founder and CEO of bEHR Health. I actually recently earned my master's in public health and health equity from bEHR. Incredible program. So if you know anyone that's interested in health equity work, it truly properly orients people to address health problems through a health equity lens, which turns out to be the best way to solve health problems. So just wanted to shout out bEHR's PhD program. So last year, my mom's good friend lost her husband to a stroke at age 46, leaving a 13-year-old son to have to grow up without a father. And you may be thinking, I thought that that's only something that happens to older people. Well, it turns out we have two types of aging. Right? Chronological aging, that's the number of years that you've been alive, right? How many birthdays you've had. And then there's biological aging, which is more related to the rate at which your body is degrading. It turns out that obviously you can't do anything about your chronological age, but your biological age can be affected by a variety of factors, such as your environment, your lifestyle. And what's happening is that Black bodies are actually aging faster and unfortunately dying earlier. Take New Orleans, for example, where you can see disparities in life expectancy as great as 26 years, such as between Lakeview and Tremaine. Hypertension and heart disease, type 2 diabetes, these age-related conditions are starting to show up in our bodies in our 20s and 30s. And our bodies can only live with these conditions for so long, and as a consequence, we live shorter lives. Again, we know what's driving this: poor social and environmental conditions, poor lifestyle habits, underutilization of healthcare. And what we focus on here at bEHR is health literacy, where 60% of African Americans have basic or below basic health literacy. So our current healthcare system, though equipped, in my humble opinion, is not designed to solve this problem. And at bEHR, we aspire to create a healthcare resource that is free from the shackles of racism infecting our current system and seamlessly integrate health into Black culture. And it all starts with our app. Now, raise your hand if you know your credit. Now, raise your hand if you know your health score. Got a few people. So, our app, Balanced by bEHR, is kind of like Credit Karma, but for your health. Okay. Real-time health scoring, personalized coaching, and access to health resources all in one place. We help people identify potential health risks early on so that their first encounter with a chronic condition can be in a conversation with their primary health care provider, not a trip to the emergency room or even worse, a death sentence. Every user receives a score between 0 and 1,000 based on the data points that we track. So when someone first downloads the app, they complete an initial health score assessment. So answer some questions about their eating habits, smoking and drinking habits, the connected preferred health trackers, so Fitbit, Garmin, Apple Health, Samsung Health, whatever you integrate with. And then you get your initial score. This user's score is 448, which is considered low on our platform. Again, it's from 0 to 1,000. Anything below 550 is considered fair or poor, indicating greater risk for disease or accelerated aging. We track mental health, physical health, nutrition, sleep, mindfulness, physical activity, and more. You can also insert your blood values and blood pressure, cholesterol levels, things like that into the app, and also goes toward your score. The health score algorithm is based on 300 billion person years of clinical data, and as more of that data, as more people contribute to that data, we'll update the score to reflect and be more precise and more indicative of current health risks. So if you go on a run one day, your score goes up a few points. If you get 3 hours of sleep one night, your score goes down. Right? So it provides that real-time update, real-time feedback on just how much of an impact your current lifestyle is having on your overall health. Based on those changes, you'll receive messaging from our personalized AI coach in the AI section of the app. You can also set rules for what we're interested in evaluating in individuals. So over time, we'll be able to see individuals that have a health score of 445 more than likely have type 2 diabetes stored there. So whenever someone comes on the app and it scores that way, we can help let them know, hey, you may be at risk based on the rest of our population, maybe at risk for this condition. We highly recommend that you go see a provider on bEHR Connect. So bEHR Connect is our directory platform within the app where people can find providers locally. Right now, we're just focused on New Orleans. So all the providers that you see listed here are based in the city. However, as we grow throughout the country, there will be more geolocation-based resources. So that's one side, so real-time health education for individuals. On the other side, we work with providers and health stakeholders to use our user data to evaluate the impact of programs and promotions and policies, the impact that those are having on individuals in real time. Most importantly, so that we can update and modify those interventions in real time as opposed to waiting 10 years down the road when lots of things have changed, obviously, over the course of 10 years. So part of what makes us different is our approach. Instead of just throwing our technology out there and hoping that it sticks, we work hand in hand with our community. Black people have had little to no involvement in the development of mobile health solutions, part of why they don't work as well for us. And so we work hand in hand with our community. It leads to more trust, sense of ownership, and people turned out that they are pretty excited to know their health score. So we host what we call community design sessions, where we introduce people to the concept of our score, have a conversation about why their score is what it is, and then chart a path to optimal health from there. So here's an example of audio. Probably should have tested this before. Anyway, so here's an example of a community design session. This is one of our student interns interviewing a student at Dillard University. He's basically explaining that he's pretty consistent about working out when he's at school, but when he gets home and he doesn't necessarily have access to a gym, it's a little more challenging for him to work out. Okay. So that's an example of what we can call in the startup industry customer discovery, but in health equity is community-based participatory research, right? Inviting the community member in as equal partners in the design and development of your products and solutions. So last year in New Orleans, we did over 1,400 of these in-person health score assessments. We learned a lot, right? Both quantitative and qualitative data. The average score was fair, or 544, kind of validating the problem that we're trying to solve. But the most important thing that we learned is that people are interested in knowing what their health score is. So we recently launched the official app in January of this year. We have about 100 users currently. And what we've seen so far is that when people know their health score, particularly how it compares to others, it's a strong motivator for lifestyle change and engaging with preventative healthcare services. One of our students in the early testing phases, her health score was about 300 points lower than her peers, and she obviously felt some type of way about that. The next 3 days, she came into the office, she checked her blood pressure. Now, our blood pressure cuff has been sitting there all semester, but now all of a sudden she's interested in putting some data in to improve her health score. Like that, if we can scale that moment, right, because she's 22. Again, these conditions are starting to show up as early as our 20s and 30s. If we can scale that behavior, I think we can make a significant impact. And most of our users are using the app daily. So our ultimate goal is to build, again, a healthcare resource for the Black community. We're starting off with a health app that just enables us to get a pulse of what people are dealing with. As we expand, as we see organic growth nationwide, we'll go and host more community design sessions and ask that community exactly what they want, what ideal healthcare looks like to them, and roll out clinics and other care services to meet the needs that those communities have. This is our team, includes myself, Dr. Brianna Sims, and now Dr. Taylor Smith. We're all Xavier grads. Around the same time, we all kind of joined forces to start this. Taylor's a professor at chemistry at University of Cincinnati, and Taylor will be starting her residency at Emory University in radiology this summer. Taylor Allen works for Microsoft, and she helps with UI UX research. Some of our success over the past year include startup incubators and accelerator programs that we've been selected for. Most notably, we did one at Harvard Innovation Labs. These programs really just help structure the approach of how we roll out our solutions. Highly encourage anybody building a new solution to leverage these principles as much as possible, because these problems are urgent, and oftentimes in certain sectors they don't move as fast as they need to. And so some of the mentality from this industry, I think, is necessary to move the needle on these issues that we care about. Couldn't do the work without our student interns. So we work with a lot of students on campus. Most of the work that they do is community engagement, as you saw in that video. But we also invite the students to have opportunity to earn equity in the company. So about 6 of our students currently have percentage equity there. And our goal is to create about 10 to 20 millionaires over the next 4 years as we scale our company. So, if you're interested in downloading the app, you can scan that QR code there. Use access code maximizing Black health to enter the app. But we're also interested in partnerships and opportunities. We need about $500,000 for 2 years of funding to truly validate and expand and grow our platform. And so any opportunities through grants primarily to do that, partnership with universities would be great. Let me did everybody get the QR code that wanted the QR code? That's all I got.
That if you do have a question, if you could just stand up, announce your name and affiliation so that the entire audience can hear your question as well.
Hello, my name is Karen Robinson. I'm affiliated with UNMS. I'm part of the Super Project. And my question is to you, Mrs. Sarah. I love your app. I love your idea. I'm sorry. I love your app. I love your idea. I know this conference is like a good place to network. So I was wondering, how quickly were you planning to expand your app to other places, and how would you go about expanding it? Because I feel like it's a great idea, and I would love to see it used in other places.
You said you're in Alabama?
No, I'm from Arkansas.
Arkansas.
I'm a college student. I go to U of A in Fayetteville, the Razorbacks, and I'm here. I'm here with UAMS, so part of the Super Project.
Yeah, the expansion is, can you guys hear me?
No.
Turn that one up, I think. Yeah, I think turn that one up.
Okay, can you guys hear me now?
Okay, here we go. All right. Figure it out. So the expansion is fundamentally connected to funding, right? So as we're able to raise more money, then we're able to expand to more cities. I think an additional layer that it's connected to is a group of students that want to host community design sessions in their local area, right? That's the first step of our expansion and whatever we do. So if that's something that you'd be interested in spearheading, then talk about it and set it up for there.
Hi, I hope you can hear me. I'm Dr. Joan Tillman from Compton State University of Baltimore. I commend all of you. Kwame, if I'm pronouncing your name correctly, the algorithm that you mentioned, the data, I'm trying to understand the collection of the data that you have is based on the profiles of certain individuals that provide the information.
So the algorithm is based on clinical research data, right? Now, your score is based on the self-reported data you put into the app, right? Which is then goes into the algorithm and then spits out a score, right? So let's say you go onto the app, you complete your initial health score assessment. You say that you exercise 2 hours a day, you drink 3 glasses of wine a week, and you exercise this much. Based on that, the score is going to do a risk assessment, essentially, and then spit out a score. Again, so most of it is self-reported from your end, but the algorithm is based on clinical data.
And what are your reference sources for the clinical data that you're using?
Clinical data of the world. And part of our role with our partners, our technology development partners, is to bring more Black data into the data set. right? So as we all know, clinical data is, Black people are underrepresented in that data. And so the algorithm actually isn't as precise as it could be for Black people. In fact, it probably skews positive, right? Because we're more affected by all health issues than other races. And so that's part of our job here, is to kind of bring more Black people into the data set.
Maybe you answered it, but the clinical data, I'm trying to understand what is the source of the clinical data? Is it a certain database that you're using for that?
Yeah, so you're asking for the algorithm data set, or you're asking for the data from our users?
So more specifically, she's, like if it's blood pressure or they're coming in, they're giving it, because I noticed that you had a lot of the in-person sessions.
Mm-hmm.
So in regards to that particular data, what is
So the data that we're bringing in from our users is not training the model, right? The model is trained based on clinical research data from just general clinical research data around the world. No, it's not from electronic health record data.
Are you purchasing that data? Are they coming to you and you're measuring?
So we partner with a development company, and they develop the algorithm, and it's based on, again, the research of the world that exists around. Yeah, that's correct. Yeah, actual Earth data.
Hi, my question is also for Mr. Kara. I'm Emily. I'm an MPH student from California, and I wanted to ask about how you actually developed the app and any advice you have on creating an app, because I'm currently working the client preceptor for LA County Department of Public Health, and she wants to develop a training toolkit that is provided to medical staff working at safety net hospitals that don't have a dental department, and she wants to be able to train these medical staffs to refer their patients to other places that do have dental care. And so I'm kind of just asking, because I know nothing about actually making an app, so if you have any advice on like different not companies, but like how to actually develop that.
Yeah, so we outsource our entire development process. My background is in public health and health equity. My innovation is on a social level. So we outsource the technological innovation to a company called Dacadu, which, if any of you guys saw the app, that's our development partner. And so, instead of trying to figure out how to develop an app myself, which probably would have taken a long time, I just outsourced it, and so that we can get the product to the market.
So you would just provide the data to the database?
You're talking about for
the app, like would you show them what you want the app to do?
Yeah. So you can create what's called a wireframe, where you have basically you do a sketch of what you want the app to look like, provides the shop, and they'll put something together.
I'll just add that as the end user, you would create the business requirements for the app. So let them know the process that you want to implement and how you want it to function, and then the technical specifications are developed by the developer.
Hi, everyone. I'm Dr. Maisha Dingley. I'm from the National Institute of Health. I'm the Office of the Director at NIMHC, actually. I apologize because I only got a little bit of, I caught the ending of several of these presentations, but my question is to you, Dr. Hawkins-Taylor, and perhaps Ms. Compton, you can answer it as well. So, all of you have used all of this data, correct? And so, have you used the SCOH module in all of this data? And if so, or if not, I'm interested in learning about some of the successes and struggles that you experience using, in particular the SCOH module, because it seems as if, even though there's oversampling for persons of color, right? The common discourse around that is we're unable to evaluate certain aspects of health equity or risk factors that are endemic in mainly Black populations. So can you speak a little bit about your experiences?
The biggest issue with the All of Us data and specifically the social determinants is the fact that a lot of people don't report that. So that data is not even available in the system. So that's the biggest challenge, that it's not there. Even if we have a tremendous number of participants or records for whatever we're studying, the lack of completion of the data, or, well, that would mostly be it, the lack of completion of that data. I was working with, Fitbit records, and so very few of us report those numbers. So that, getting people to be more complete would be really helpful.
I think I would just add, I do not have experience using the All of Us data, so just to be clear about that, but I'm very interested in learning more about it, and I'm glad Mariana got to talk a little bit about it. What I would say though is, what I think is really fascinating about having a database across the country is that you can start to think about places that wouldn't have that oversampling, look at a larger denominator of population that spans different racial and ethnic categories, and then you can start to apportion that data to a smaller geography, right? And you can get a little bit of a wider sample from a larger source of data, which is what I think is fascinating about where my sidewalk pairs with data like All of Us or like EHR data. You have something from a specific population or place, but if that is oversampled, or like I was talking about in a clinical trial setting, if you're oversampling your trial participants and then your results are biased, right? And your drug is tested to impact a particular population. When another population takes that drug, it's going to impact them differently. And we need to make sure that that's not happening in our drug development and health initiative development. And so pairing those sources together, I think, can get you a more comprehensive understanding.
One more issue is, so we're doing all of those things that my colleague talks about, but it's really a lot of data that you're asking for. So there are 5 different surveys that all of us ask for completion. There's the access to the EHR, there's access to the biospecimens. So that unearths old issues with the Black community of being used as, so some way we have to be able to communicate that we're only trying to encourage them to participate so that we can have access for the understanding of the issues of our community in a positive way. So we need to be stronger in that communication.
And then there's no real way of, after collecting the data, besides, listing the publications on the website, to communicate to those communities, this is how we use your information.
So the community dissemination is also a struggle.
Yeah, thank you for that.
Hi, Jose Rosario, Tulane School of Medicine. So my question is for Mr. Kara. So as a person in the space of precision risk development, I'm wondering, you mentioned in your presentation that the app uses the health data of participants to generate recommendations for particularly chronic disease. I'm wondering how actionable that is, as in how do the people who are using the app respond to that? Do they actually act on the advice? I know that that's been an open question in the space.
Yeah, I mean, that is the golden question, right? How do we get people to actually act on health information? It's just based on how well we break it down and make it actionable for them. So what we've seen so far with some of our early users is that if we just give them the app and let them kind of figure it out on their own, the engagement rate drops significantly. If we spend like 30 minutes to an hour with them, kind of walking them through the platform, helping them understand what cholesterol means and what blood pressure means. And I'm saying this is like on a basic level for even master's level educated individuals, knowing what your systolic versus your diastolic blood pressure means, right? She's like, oh, so the numerator and denominator. That's what it's going to mean to her. That's what is going to make sense for her. And so I think I just have to take that time, that time to actually educate and help people understand exactly what they're looking at. Because once it clicks, then they become kind of like, health nuts a bit, and they're tracking their health all the time, and then they're more aware of how everything that they're doing is affecting their life, but you have to spend that time.
I have a question. This is a great presentation. You talked about one big thing, trust, and about data. So I'm a nurse, I'm Mount Sinai, I'm DFE graduate, and I work with a lot of Black and Brown communities. I may go into a room and assess a patient and ask questions. You may go into a room and get two different answers. Building that trust is something we have to think about in data collection. You talk about limb in Black communities. I walked into a room with my white coat on as a DNP, and there was other physicians in the room that didn't look like me. And he had a limb sticking out, his femur was out. And he was asking me as a Black woman to talk to him about amputation. He got irate. So in order to speak to the data, sometimes our collection has to be on point. How do you guys safeguard the trust of Black and Brown communities in collecting that data? That they trust you, because you speak about trust, that's my biggest thing, is trusting that I will protect you and keep your data safe from all data breaches around the country. Can you guys speak to that? Thank you.
I know, for research, I am not in the part of the research, but I am in the part of how to get to the community. Yes, trust is very important. One of the things that we are doing with the All of Us research program is to, at the same time that we are educating people, we are giving to them the information about the privacy, what is needed, respect about the names. Usually in All of Us, when you register, automatically everything is codified. Is no names, is no social security number, especially for us as a Hispanic community. Anybody can participate. They don't need to have a social security number. Also, the codification help a lot because the name disappears as soon the information is there. That is something that really make them trust and also do a follow-up. We not only invite them to be part of this, we educate them about the ancestors because they get the DNA free. They don't have to pay for that. Additional to that, they have some compensation. The compensation is not the big thing. The education is the most important thing for the community to participate. And then later to do the follow-up. For example, the All of Us research program now, after you are enrolled, you have the other program for nutrition and also for mental health. That follow-up is a very trusting thing for the community to continue participating in research. Because research, sometimes people are in research and they have already what they will do, but they don't have the people who are going to participate. Then we have to think first, what is the need outside? What that community need? Yes, trust is very important. And we had to go, like you say, for the Black community, for the Hispanic, we need some specific lines to take care. Some specific things that we really need to pay attention before we go to the community.
I wanted to add to that a little bit because I think that's exactly right on the front end, right? Like making sure that you have people already who are ingrained in particular communities to help with that front end data collection. Also, I think it's really important for institutions like universities and state health departments and local health departments to then hear that feedback and put it in their solutions and the way they present it back. Because a lot of times we miss that feedback loop, right? People give their time, they sometimes give their information, and then they don't hear anything back. And that is a huge problem, and it creates the mistrust. And so back when I was talking about our work with Louisiana State Health Department, those community advisory groups are continuing and engaged in the process. The dashboards that are put out there are accessible both from a written health literacy standpoint, but also they themselves, their input is truly on that website. So not only are we away from providing out PDF handouts to where we can't really share things across geographies, but we also can say, this group of people decided that this was the most important thing. A lot of times policymakers and other folks come in with a storyline in their heads, right? They think we want to impact this thing, so we're going to steer the story towards this thing. And that's not what the community is saying. And so I think it's as important on the front end as on the back end when you're presenting that back to say, we heard you, and we're going to shift the way we allocate our resources or the type of policy initiatives we're going to take on to reflect what you're saying.
Well, I was, just for a second, I'll address her question. And so the issue of trust is a perpetual one, and I don't think it's one that we solve. I think what Kwame's doing specifically is empowering, because he makes the community a part of the conversation, he makes them partners. So I think the partnership with the community is a big issue. Dissemination is one thing, but including them in the conversation from the beginning and making them part of the solution and not just the recipients of the solution is a big help in building trust.
So I want to ask the question just to kind of, before going to the audience, just to build upon what you all were saying. So how can we ensure that whatever data is utilized, or just the theme of whatever that particular topic that's identified or taught about, is community driven, so that it drives the data? Because a lot of times, oftentimes we'll have research, several different projects. Researchers, investigators, academicians have a thought in mind of, because based on our particular interests, our interest drives the research. But that may not necessarily be what the community needs. That may not necessarily be what the community wants. So how do we take a step where we are right now, because we know that, and instead of continuing to have several different projects that are funded that may not necessarily provide the funded resources to that community, but focus on making sure that we initially incorporate the community from the very beginning to say, hey, this is the area that we definitely want to focus on. What are your strategies or tips? And then I'll open it up to your question as well.
I think it comes down to educating the industry, right? So when I came into my NPH program at Xavier, my perspective on how to solve health problems was different than what it is now. There's no way we would have done community design sessions to launch our platform if I didn't get that education, period. So I think that it fundamentally comes down to that. And then scaling that mentality and going into it assuming that you don't know the problem or the solution. Like just deciding, even if you probably do have an idea, right, of what the problem is or an insight, just assume that you're probably wrong about that, just so that you get into that conversation with an open mind. Because health equity work is really about going to people, finding out what their problems are, and asking them how you can help, period, right? It's not, I have this cool idea that's targeted to Black people, or I have this cool idea that's targeted to Hispanic people. It's like, I'm going to an individual, I'm going to a family, I'm going to a community, asking them what their problems are, and then asking them how we can help. And then maybe later on, if whatever initiatives that we had planned can be worked in, but health equity is about restoring people's quality of life, fundamentally. That's what's been taken through years of injustice, and what we have to restore. I don't think that it's more complicated than just taking care of people. So that's what I would say. Yeah.
Partnership for me is very important. In community engagement, you have to go to a place. It's true, you can go to the community, but you need to have the connection. You need to have a partnership already, because there's so many organizations already working there. They know the community, they know the people, they know the need. So that is the best way for us, was to go to these different organizations and see what was the need, and through them open the door to the group of people. Just that we have that connection, that we can come and really get the information that we are needed. And for me, work a lot the partnership and being involved like with education, because for me it was a lot of education through Saber to all of us of all these programs before I go to the community. And I always share with them, I learned this, I believe it, because that is the best way to do it. I got enrolled because I know many people are in different researches and they are not part of it. They are only in the project, but they are not enrolled. So that is one of the things we have to be part of in order to give it to the other people to invite them. One thing that worked a lot in the community for the Hispanics is they see people who are Latino, they go for it. Is they, we facilitate everything in Spanish and English because that is the community I am a Golden Change trying to get right now. Even though we work with all the groups, but we are right now working because that is all of us concentrating right now. They need diversity because it's so many diseases and for the precision medicine, we need to have more data available. So that is if anybody wants to be part of all of us, we have the QR code and we have the business card here.
I wanted to actually provide one more follow-up to your question about how to get people to stay engaged. There's this concept called variable reward, where when, for example, you do something, you get a reward. If every time you do something, you get the same reward, you're less likely to engage with it. But what the health score on our app provides is that variable reward. One day you wake up, your score went down 10 points. Why? So you go look why, and then maybe you change your behavior as a consequence. The next day you wake up, your score went up. Now you're excited because what I did yesterday improved my score. So providing that real-time feedback as opposed to I go and get my blood pressure checked one day, then I go get it checked 30 days later, and there might not be any significant change. I think that day-to-day update is really powerful for behavior change.
I saw 2 hands on this side and then I saw your hand as well.
Okay, hello. My name is Alvin Schilling. I'm an assistant professor at The Ohio State University. I engage in community-based work for cancer prevention. My question, I'm interested in tech, I believe futures tech, now it's tech. Actually, I work to understand the use of the patient portal as well for cancer screening promotion. But after hearing Kwame and Mariana speak, my question is, and also in light of this recent conversation, you're using 2 different approaches. You have an app and then you have a website. So in looking in the space of community engaged work, which do you feel provides a better reach? Is it the app, which is somewhat a closed system, or this website, which seems to be open platform? So I was curious your thoughts on that.
Well, all right, real quick. So people always ask me, like, what happens when, an older person goes to use your platform and they're not tech savvy? Well, that's not how we're going to deliver healthcare to them, right? So again, I don't want to make anybody use my platform if that's not the way that they want to receive care. And so maybe it is a website, or maybe it's they only are willing to talk to people on the phone. Again, instead of necessarily trying to create a blanket solution for everybody, we have to do the real work to tailor the solutions to each individual's need. Yeah, that's what it is.
Okay. For us, in the Hispanic community, you have to get more closer to them. You have to be more like providing information in hands on what to see them. Because it's very important they see you and they get involved, when you are doing registration for any project and they see you part of that. So that is a trusting thing that they will follow up. So for the community, the Hispanic community is a little different because they are not used to research. We are not. So for us, it's double education. So it's more, can be webpage, can be meetings. We have a lot of the groups, focus groups, where we can hear the community, say what they needed. But one thing they always say is we want to go to the community, the Hispanic community, we have to be sensitive with the language. So then we have to have material in Spanish in order to go to them. Even though they speak English, they will love to read in Spanish too.
Oh, sorry, yes. Okay. So I'm Jill Keith from Winston-Salem State University, and Mr. Tara, am I saying it right?
Sure.
Okay. I wanted to know, do you get like funding from SBIR or STTR grants?
Not yet.
Okay. That's part of the telling. Okay, I was gonna say, there are, because I'm in the same boat, always getting grant money. And some states, like North Carolina, will match it. So if you get it, they'll match it 1-for-1. So we have poor health outcomes as well. We use our students to go into the communities with us to help build trust at some property HBCUs. And the students do very well, and we engage them in the research as well. So our student interns, we train them for community engagement work. They go along with us. We go back and disseminate the information as well, and the students are trained so that when they get their degree, they're able to continue the work. So that, to me, that helps build the trust. But I was going to say about the funding.
We go there, and it doesn't matter. She is from, from the different group, and they open the doors for all of us. Yeah, they start talking because she is now knowing that group. But we went through the leaders, through the principal of each organization. Now we are with 5 different organizations, and Golden Change, we are doing like liaison, going to the Latinos. So again, the best way is to go to the people who already are there, the leaders who already exist. You have to go, you cannot go and present yourself from nowhere, because they are not going to trust. It has to be through that group. So we had a success event with the Latino community and Xavier University for many, it's like 3 years already.
And to add to Ms. Mariana, I think what's important is being present. So it's very, very important to make sure that you're not going to the community for your own agenda. And that's how you establish the trust. It's really important in making sure that you're building that relationship, that you're developing those partnerships. Oftentimes, we may not even ask them about even any data.
Yes.
Because we have to make sure that we're establishing that trust first. And as a healthcare provider for myself, I know a lot of times healthcare providers or researchers may not necessarily have the time to be present, but it's important to be present. So like she mentioned, I'm at the events. I'm making sure that I'm having the conversations and I'm meeting the other community members and just different things of that sort to continue to establish that trust. And that's very important. And being able to go back and give the information of what has been found and identifying those continuous barriers, identifying those continuous challenges or concerns that they may have. And then that continues to help us to come back to our group and say, hey, this was something that was discussed. Let's make some changes here. Let's make some changes there. Let's kind of reorganize what we were thinking about initially because it may not work. And I feel like that's very, very important in terms of just really being able to develop those relationships over time. And it may not even happen overnight.
Yeah, so the pastor said he wanted to work with us, and we were giving money to help the church with some of their projects as well, but we were still not able.
We had to talk about it. I would love to help you if I can.
Other churches did it. Other churches we worked with, we went back, we gave them that and everything, but now.
Yeah, and also, the information has to be, like in the case of all of us. When I start with all of us and they have all these providers there, I say, if you really want to get Latinos, you have to have somebody who answers the phone in Spanish. And then, everything has to be in their language. Even though they speak English, they feel more comfortable when they are speaking their own language. That opened doors a lot. And we just got a point that all of us in Louisiana is very high percentage of Latino participating because of the investment they have. LSU have employees who speak Spanish. They answer the phone, the phone answer is a person who speaks Spanish. So that is bilingual everywhere. So that made a big difference when these people will participate in any research.
We had a question here and then this question here.
Thank you. I'm Dr. Melvin Black. I'm Deputy Director for the Public Health Department in National Tennessee. And actually, I feel like I'm coming home. I'm a Dillard graduate. And just excited to be back home, essentially, and to be a part of this conversation. I was really thinking about all the presenters and just feeling this confirmation that the work that we're doing specific to my department and the question from the lady from NIH, that we're headed in the right direction. About 2 years ago, we bought into the community health worker model. If you're not familiar with CHWs, it really is an opportunity. We hire in several staff persons that are from the respective communities in our county. And they provide the connection with the community to do the work that many of you are talking about and that you're doing. And it also allowed us to get that trust and confirmation from community for data collection, for behavioral change, behavioral consistency, and as well, kind of on the gun violence side or violence interruption side, we've hired credible messengers, which kind of mirrors the CHW model, because we hire people from those respective communities that have involvement, and they serve as a voice for their respective, even micro communities. So I think just hearing the conversation, we're headed in the right direction, but I know that there's much more work to do, because we still have to build out persons who will buy into the model and continue to help generate the data we need to be forward-thinking, to help us implement models that will continue to grow communities' health, better outcomes, and the like. So thank you for all the information that you deliver, but more importantly, thank you for confirming that we're headed in the right direction.
Good morning, and congratulations to each of you for imparting really important information. This was a very rich conversation. I have a question, and I also wanted to share some information in relationship to Dr. Jill's point. My name is Patricia Jones. I'm with the National Institutes of Health, specifically the National Institute on Aging. I'm the director for the Office of Special Populations. We collaborate with our small business program to offer a challenge prize competition. We just closed the second round, and those resources, $60,000, you can apply, go through the whole entire boot camp experience if you're selected. We connect you with angel investors, attorneys that know proprietary law, help you get to the place where you can bring your innovation to the marketplace, and that if you win the competition, we choose 5. Those $60,000 can be used to take your innovation to the next step. So I just wanted to make everyone aware that there are people interested in the health department to build out innovations, and so just wanted to share that resource. But then my question is for Ms. Kaufman. You mentioned a risk index that was applied in Houston and the collaborators, and I'm just wondering if you could share a little bit about how the index was validated with different populations, and if there's any plan to expand more broadly as chronic kidney and other health implications could benefit from having a validated instrument.
Yeah, it's a really good question. So the team at Houston Methodist developed that risk index in their first year of AIM-AHEAD funding, so the AI Machine Learning Consortium through NIH. They are currently partway through their second year of funding, which is the time to develop the community consortium and kind of revalidate. So they did the validation with the secondary data, and they said, hey, we noticed a really interesting pattern that kind of confirms, as we talked about, right? We might come into a research project thinking we know what the patterns will be, and then we're either validating those things or we're surprised and we change our direction. And so now they said, hey, we have this pattern happening. How can we make sure more people have successful transplants? And so now they're coming to build this consortium of community organizations. So I think over the next probably 18 months is when they'll start to do that validation with community input. And that's the piece that we're supporting them with, to then say, okay, how do we take the community input? Think about that in terms of other available data sets, and then display and disseminate that data in a way that makes sense to all of those audiences.
Thank
Any other questions?
Hello, my name is Curtis Colbert. I'm from the Southern University Law Center. And Mr. Terra, I've got a question. So you said that your app tracks physical and mental health.
Mm-hmm.
So when tracking mental health, does the algorithm treat mental health any differently than physical health? When it comes to the questions you have to put in terms of the responses that you get, are they also treated differently in terms of the score that comes back from it? And is mental health, in terms of like how mental health and physical health come together to create that score, is mental health treated any more, any less than physical health when it comes to getting the score?
So you get a score in each category. And so while you may have a good score overall, you may have a low score in the mental health category, for example. Our mental health score is based on psychometric data. So when you go into the mental health section, you answer a series of questions, about 14 questions, just basically about your mental health and how you're feeling about, for example, do you feel sad or depressed on a regular basis? And it's on a sliding scale. That's how they're different. Depending on the data point, because we track over 100 different data points, and how that data point relates to health risk, they are weighted slightly different. For example, it turns out that how someone feels about their overall health, and so do you feel that you're in good overall health, is nearly as predictive of longevity as blood pressure, right? And so these are, again, things that the scientists discovered in the development of the algorithm that have been very powerful for providing insights into how this platform can help people manage and understand kind of where their current health risks again through a holistic perspective, as opposed to just looking at blood pressure and stuff. Mm-hmm.
Oh, also, would I be able to get the QR code again?
Yeah, it's bearhealth.com, BEHR health.com, or I can give it to you after.
Yeah, because I was trying to download the app and use the QR code app. I think I have to do it again on the screen. Once you get in the app, I try to get in.
Yeah, we're just going to talk to me after.
Hi, my name is Corey Williams. I'm a fourth year med student from Louisville University. I'm studying oncology. My question is, my population is 6 substance, and their pain management goes up and down daily. And my question is, if they put in their information in their database, will it change or will it affect it? Like one day it's higher, and the next day it's low. How would I see if that comes about?
You said you're talking specifically about pain?
Yes.
Yeah, we don't evaluate pain in the health risks. It's essentially a mortality risk engine, so pain isn't a factor currently.
As far as their pain affects their behavior as well.
That's true. Well, so let's say their pain is affecting their behavior, which is making them less active, for example. So then they'll see a knock on their score because they're less active. And what you're able to do again, so people are using our platform and we're collecting all this data, but you're interested in a different question. For example, how does pain affect longevity, right? So we can have a conversation about putting together a project to evaluate that, but we have to collect that pain data in a separate way. So we could either do that through a Google form within the app, just to see if we can draw some correlations between that and individuals' health scores. That makes sense?
A little bit, but I get what you're saying.
Yeah.
Thank you.
I actually have one more question for just a person for using analytics. Dr. Gary Bennett at Duke University, he was able to improve the health outcomes of the Black people in Durham based on collecting a lot of data from them and having them make small changes. And so their obesity levels went down. So if you look up his work, I don't know what algorithm he used or anything like that, but he's successful, so he got promoted to like being so I don't know how much he's doing, but he had very good results. He said, I didn't even ask people to change a lot. He said, I just asked them to change have an algorithm that's used to help them where to make changes and if they make a difference. So I don't know.
Yeah.
Now, we have time for 2 more questions before we hear closing remarks from our panelists.
Thank you very much. Dr. Tulare, founding physician at Howard University, comment. Thanks for your innovative work. I do have a few recommendations. So I missed the question that you presented, so bear with me if you already addressed this. I would recommend that you work with physicians, family physicians, if possible, to give input into your application and some of the analytics. And also be cautious about medical decision making because some of that is regulated. So if you're giving recommendations to patients, to get into that territory. So just something to be mindful of.
Yeah, so at this stage, we just recommend lifestyle modifications. And we are going to work with healthcare providers. We actually have a Dr. Griggs that we partnered with recently. If anybody knows, Dr. Griggs is a local community health physician here in the city. And then as we roll out clinics, right, all of that will be formalized through. Yeah.
Here's another question.
Hi, thank you so much for very good presentation. My name is Sarah from the International Association for Service-Ready Community Engagement at Tulane University. Because my question for promises a comment about the database. What is your framework to providing and creating this database? Are you focusing on specific research topics and based on community needs and community concerns, or are you focusing on clinical trials or any other social determinants or environmental issues that the community is facing challenges? Because I want to know how is your framework for creating this a broad database that you're providing is for specific research topics or considering specific communities and what geographic location you are considering? Is it national or just in the local region?
Yeah, great question. Thank you for that. So our database is national. We collect data from over 50 different national sources. So that includes data from the CDC, from the American Community Survey, from the EPA. We do purchase some data sets too, like for example, around noise pollution and how that is impacting health. So we don't focus on a particular topic. Our mission is to provide this robust data library that's really flexible and really easy to use interface for anyone working in community health who wants to use population level indicators that are in an aggregate, geographic aggregate format to inform research that you're doing, to inform community health improvement plans for a policy strategy. So it's really broad. And in terms of geography, our data is available anywhere from the state level down to the census block group. So you can get really precise in a geographic location and work on sort of a smaller scale community initiative. You can broaden that out and say, how might we influence this state level policy? And we want to incorporate data from all over our state, which has different population densities, different health outcomes, different structural drivers of health. So it's pretty broad.
And are you selecting research methods specifically for collecting data, or how is your process?
Yeah, so we don't collect primary data. We curate and aggregate data from sources that are already collected and have those methods that they have on their, from the actual source. We allow our partners to integrate their own data from which they'll have their own methods. So we are sort of the step removed from that community participatory research. We're sort of providing that backbone of how does the experience in a community, how's that reflected in a national data set, and how can those national data sets help you prioritize where to maybe focus certain initiatives in your community. Does that make sense?
Are there any no-cost components to your platform?
So right now it is subscription based. We are on a path this year where we are working on some AI tools that would allow you to, ask a question about, rank the prevalence of diabetes diagnosis across each parish in Louisiana. And you could ask that question in natural language and it would give you back that data. It would allow you to you could ask it to create a map and it would create you a map. Right now, so I think in the longer term, we may end up having that no cost sort of entryway, but right now it's subscription based. Like I said, we're trying to work towards a model where we have larger organizations that have that funding and capacity purchase those licenses, and then kind of that train the trainer model, right? So community members are able to see and interact with that data, or maybe community-based organizations who don't have the capacity to purchase that type of subscription can have access to that data, and then they are the ones who are there helping communities see themselves in that data. So we're hoping that model might help with some of those funding challenges for smaller organizations.
So let's give a round of applause to all of our to each and every one of you for joining us. I mentioned this at the beginning that every time I come to this conference and just hearing a lot of the work that is being done, I'm always inspired. And so we see here that it's very important for us to be able to engage our communities, making sure that we build their trust, that we collaborate, but most importantly, that the work continues outside of this. And specifically, the conference just really coming together to be able to develop solutions, strategies, and us being able to press forward so that we can make sure that we are achieving health equity. And so I thank each and every one of you for joining us. Very excited about our next opening session, so I hope that you will join us there. And this is the continuing education code. So if you are interested in receiving credit, an evaluation form will be emailed to you, and you can complete that form and place this information on there. So once again, thank you all so much. Thanks to our panelists, and be blessed and have a great day.
Let's go over there. Okay.
No, I'm not having this discussion this year.
1, 2, 3. 1, 2, 3.
I'm bilingual major in
I would love to talk with you about these my information to you as well. Social are so it's critical, and there's a that is like they don't have your long physical and yes, okay, yes. We do, I mean, with the you want to concern that we can do feedback
But a lot of
genetic areas, but our work is really to provide genetic data platform for you to then both use and disseminate your findings. So we don't do a lot of the research and method. We have a team of data scientists who sometimes take on different projects, right? We are really in this together. That's different than you just accessing our data and creating reports and share. I'm
which is compensated.
It's so nice to meet you. I look forward to seeing
They will know this because they know to share.
you should take the state of Florida and
It is the best way
more outreach.
That's so interesting.